Active range of movement for hip flexion. In the supine position, I ask the client to bend their leg and bring their knee towards their chest. This gives us an indication as to how far the client feels comfortable to move at the joint. This is also active range of movement, but for abduction. For this, I ask the client to keep their leg straight and flat and bring their foot off the couch to reach my hand. This may highlight any pain the client has, and testing it on both legs allows us to compare each side to the other to identify abnormalities or differences between them. Here I am repeating the same process, but for active range of movement for adduction. For this movement, I also ask the client to hang their other leg off the bed to stabilise the hip so that the other side does not aid their movement. This is testing for active internal rotation of the hip. I first demonstrate to the client the movement I would like them to perform, then place my hand as a guide towards the midline of the body for internal, and allow them to try and get their foot to reach my hand on their own. I repeat this process, but this time to test active range of movement for external rotation. Again demonstrating the action first, then allowing them to try and reach their foot to my hand by themselves. For external, my hand is placed on the outer side of the body. The final active movement is hip extension, which requires them to be in a prone position. I ask the client to get their foot to reach my hand as high as possible, whilst keeping their hip flat on the couch and maintaining a straight leg. Next is testing passive range of movement for hip flexion. For this, I secure my hand at the bottom of the foot and below the knee, and push the knee towards the client's chest. This shows me their full potential of flexion at the hip joint, and allows me to assess the end feel and quality of the tissue's resistance at the joint. This is testing the passive range of movement for hip abduction. I do this by moving the leg via the ankle away from the midline of the body, whilst securing the other side of the hip so it does not lift off the bed and increase how far the leg can be pulled outwards. Similarly, this is testing for passive range of movement for hip adduction. Again, I use the foot to pull the leg towards the midline of the body as far as it will go, whilst the client secures their other leg over the couch and I secure the hip. This is testing the passive range of movement at the hip for internal and external rotation. In the prone position with their knee at a 90-degree angle, I bring their foot towards the midline of the body for internal rotation and away from the midline for external rotation. I do this by using the foot and by securing my hand at the knee to avoid knee rotation or foot inversion or eversion, which could aid in their movement. The final passive range of movement tested is hip extension. I do this by lifting the limb with two hands as far up as it will go, whilst ensuring the leg is straight and that the hip maintains contact with the bed, so that lumbar extension is not present during the test, which could otherwise lead to an increased range of movement. Resisted range of movement requires an external force. Here is me testing resisted isotonic movement at the hip during flexion. Isotonic means that the muscles change length whilst contracting. In this case, the quadricep group concentrically contract, meaning that the muscle shortens in order to flex the hip and resist the force that I'm applying to push their leg back towards the couch. Here, resisted abduction of the hip is being tested. The client starts with their leg in an adducted position and pushes against my force to bring their leg out into abduction. This is to test the strength of the movement, and it can therefore help practitioners identify limitations to bony structures or connective tissues such as tendons and ligaments involved in this movement. I repeat the process for resisted adduction of the hip. This starts in abduction and the client resists my force to bring their leg across the midline of the body into adduction. Again, here we are looking for the strength the client exerts and points throughout the movement that are deemed weak or poor, perhaps due to injury. This is resisted external rotation of the hip. For this, the client starts with their leg in internal rotation and pushes against the force I am applying to move their hip into external rotation. I apply the force at the foot and I secure my hand at the knee. Similarly, this is resisted internal rotation of the hip. For this, the client starts with their leg in external rotation and pushes against the force I'm applying to move their hip into internal rotation. Lastly is testing resisted hip extension, again isotonically. For this, I face the client's feet and secure above the back of the knee and the distal calf, and apply downwards force to the leg whilst they push upwards, extending the hip and resisting against my force whilst also ensuring their hip stays on the bed.